Hi there, this is Professor Walton, and today we will be discussing how to care for a child who has endocrine or metabolic disorders. Started with a brief refresher of anatomy. So keep in mind when discussing the endocrine system, this is what regulates the pace of growth and development, coordination of the male and female reproductive systems, enabling sexual reproduction, maintenance of an optimal level of hormones for body functioning is seen here. You also have the maintenance of homeostasis, and then it also maintains hormones, right? So hormones are the chemical messengers secreted by various glands that excrete effects on cells in the body. So when we talk about hormones, we also want to talk about positive and negative feedback. So as far as positive feedback, that's seen when hormone levels fall. The hypothalamus secretes releasing hormones that stimulate the pituitary gland and release those stimulating hormones that affect the target organ. When negative feedback happens, this is when those hormone levels are too high and the hypothalamus secretes some inhibitory hormones that stimulate the pituitary gland to release those inhibitory factors. Have a picture just reminding you what those endocrine organs are. So you have your hypothalamus, the penile body, pituitary gland, thyroid, parathyroid glands, adrenal glands, pancreas, gonads, which consist of those ovaries and testes. Let's talk a little bit specifically about pediatrics. You've learned about the endocrine system for adults. So now let's look at those pediatric patients. So when we think about that, keep in mind that, the endocrine system is responsible for that sexual differentiation, and that happens during fetal development. It's also responsible for stimulating growth and development during childhood and adolescence. So whereas that doesn't come into play when we learned about adult patients. You see a table, and it just is giving you a representation of the different areas that you are going to assess pertaining to the endocrine system. So with this, you're going to be looking at the weight, the length, or the height. That's going to be plotted on a growth chart. So you want to look back and look for growth patterns. And then looking at their vital signs, are they comparable to the normals? Are there any unusual features? So, is their tongue protruding? Are their eyes protruding? Do you see a moon face? Are there any hirsutism? Do they have an enlarged thyroid or goiter? Looking at their strength and muscle tone, is that adequate? Do they have any cramps or tremors? And then looking at sexual maturity rating. Are they early? Is there a delay in that puberty? What does that look like? And then what about body odor? Do you smell any like sweet or musty smells? Any cheesy, sweaty feet? You're also going to be assessing skin color. And then affect. Do you see any anxiety? Are they irritable? Are they lethargic? And then look at their family history. Are there any delays? Are there any other issues pertaining to endocrine system in their family history? We're going to talk about growth hormones. Specifically, we're going to look at the growth to hormone deficiency or hypopituitary. So as far as pathophysiology, you're going to see a delayed growth pattern. They have a short stature, and that's normally below the 3rd and 5th percentile. So keep in mind when we think about etiology, there is an infraction of the pituitary gland, central nervous infection, tumors, brain tumor, chemotherapy, and psychosocial deprivation, which can kind of cause these issues. So Generally there's just that failure of the pituitary gland to produce that hormone. Um, you know, like I said, you're going to see delayed growth with these patients, and they'll fall below the fifth percentile for height. You may also see a delay in puberty, immature facial appearance, poor muscle mass, and they may have a low birth weight. Some causes can be an infarction to the pituitary gland. Things like sickle cell anemia, central nervous infection, tumors, and chemotherapy can be seen. A growth hormone deficiency, some signs and symptoms that you will see are an absent or delayed growth in the first 2 years of life, grow less than 2 inches per year. Their height and weight kind of plateaus. There's a delay in that closure of the anterior fontanelle. There's a delay in getting teeth. There's a greater height and weight ratio. There's a greater abnormal fat. They have some extra abnormal fat with that. There's a decrease in muscle mass, a protrusion of the front skull bones, a delay in puberty, hypoglycemia, and a bridge of the nose that has poor development. So a lot of times these kids have a kind of look like a cherub. They have those cherub facial features. So they've got that higher pitched voice, delay in getting their teeth, the delay in that sexual maturation, and they'll look a lot younger than what they actually are. So when we look at diagnosing this growth hormone deficiency, you're going to be looking at that growth chart. Generally, you've got girls 10 to 13 and boys 12 to 16 that are growing less than 5 centimeters a year. And you'll also see that flattening of the growth, the child's normal growth curve on that growth chart. So any child whose height is 1 to 3 standard deviations below the mean height for that age, or they're falling off the normal growth chart, needs to be evaluated. Some ways that we also look at this are with radiographic imaging of the hands and wrists to evaluate the stage of the bond ossification to confirm that chronological and bone age match. We also do MRIs, that's of the pituitary, to see if it has a tumor or maybe it's malformed. We also assess the growth hormone level. And keep in mind, we do that because medications can be administered to stimulate that release. And treatment for these patients who have a growth hormone deficiency are to replace that hormone. This can be done by sub-Q injections until they get that acceptable height. And the bone age of 14 in girls and 16 in boys is when this treatment is normally stopped. Child has been diagnosed with a growth hormone deficiency. Some nursing care that you will be responsible for are growth measurements being obtained at least every 6 months. The child and family is going to need lots of support, so you're going to need to connect them with support groups. And then provide education. So you want to treat the child for their age, not their size. Again, they're going to appear younger than normal, but mentally they aren't. And so you need to be looking at that and assessing that. And don't treat them like they're younger than what they are. Keep in mind that they'll do best in sports where size doesn't matter. And you're looking at age appropriate dress. Sometimes, these kids should be wearing more adult size clothing and more teenager clothing. However, it's hard to find that to fit them. This can be very emotional for them. They're short, they're treated younger than what they are. They're probably going to get teased by their peers. They're going to have altered body image, and they may have to dress different. What fits them. They may have to shop in the little kids section rather than the styles they prefer. So you want to help them to try to adapt to that or find clothing that works for them. Um, so when we talk about growth hormone replacement therapy, that's going to be administered sub-Q, generally at bedtime, for 6 to 7 times a week. The expect is for them to grow at least 2 centimeters every year. And then it's generally given until a child reaches a desired height or until the growth plates close. So you want to be giving them lots of education about this. Needles are scary. You've got to teach them to rotate the sites and know that therapy is very, very extensive and it's going to put them at a higher risk for malignancies. However, this does take a while to complete the therapy as well. So educating that child on how to give those injections correctly and rotate the sites is very important. A lot of times you'll see this medication in a pen type form, so it is easy for the children to administer to themselves. We're going to talk about precocious puberty. This is when the pituitary is hyperfunctioning. Patients develop sexual characteristics before that usual age of the onset of puberty. So generally they'll start to get these secondary sex characteristics. With boys, it's 9 years of age before they turn 9. With girls, it's before they turn 8. Some things that you'll see with boys are pubic hair, axillary hair growth. You'll start seeing vocal changes, testicular enlargement, and penile growth, as well as ejaculation. With girls, you'll see this breast development, pubic and axillary hair, growth spurts, and early menarche. So what happens is the hypothalamus is prematurely activated to secrete the gonadotropin releasing hormones. As far as etiology, a lot of times these kids will have some bone fusion resulting in short adult stature if it's not caught early on. There's no known causes. However, they think that, oftentimes it can be caused by a tumor or a genetic condition, which is really rare, or again, there's just that no known cause. Obesity, things like hereditary stress or environment exposures, those adrenal tumors and those central nervous system tumors can also come into play with this. So I want you to pause the video and to go and look up the youngest girl on record to ever have a baby. That is a very scary picture. You can read a little bit more about it. I always encourage students to do that. If we're in class, I pull that website up, and generally this really sticks with them, and they remember this diagnosis going forward. When this happens, some signs and symptoms that you will notice are general signs and symptoms of puberty. They'll have advanced bone age. There'll be early closure of those epithelial plates, causing them to have that short stature. It can also cause advanced bone age and early closure of those epithelial plates. Like I said, will be very short if they don't get treatment, so it's important to get that treatment. When we look at diagnosing this, you're going to be looking at lab tests, looking at those luteinizing hormones, follicle stimulating hormones, testosterone, estradiol, the release of the gonadotropins is what confirms the diagnosis, and as well as the bone age confirmation. When we look at treatment for this, there is a gonadotropin releasing hormone analog. Things like Lupron and Ceneryl can be given. They are given until a more normal age for puberty is reached, normally around age 11 or 12. The Lupron is an injection, and the Cinerel is a nasal spray. Nursing care with this. These clients and parents are going to need lots of education on the condition, the treatment, the medication, and the physical changes in their body image. Emotional support is highly needed, and an accurate record keeping of those growth rates and the decline in that. So some things to remember that the child's social, cognitive, and emotional development matches their actual age, even though the physical development, how the child looks, is advanced. They still are younger than what they appear. So you want to treat and dress according to their chronological age, and you may need to prepare the parents about discussing issues of sexuality earlier than normal. So, some signs and symptoms that you will see with hypothyroidism is an infant will have large fontanelles, a protruding tongue, they may have an umbilical hernia, constipation, lethargy, and prolonged jaundice. And these will appear within the first few months of life. Going forward, the child, you'll see a short stature for age, you'll have a weight increase, delayed bone and dental age, delays in developmental milestones, puffy facial features, severe mental retardation, protruding abdomen, that umbilical hernia, dry skin, and sparse hair. And some other common symptoms are a decreased appetite, cool or dry skin, depressed deep tendon reflexes, bradycardia, constipation, abnormal periods, and goiters. This slide talks about diagnosis, treatment, and nursing care. So generally, diagnosis is done during the normal routine screening. They're looking at TSH and T4 levels. This screening is mandatory in all 50 states and has reduced the intellectual disability associated with this disorder. As far as treatment goes, it's treated with levothyroxine. So you never want to put this medication in a bottle of formula, because then the infant might not drink all the formula and they wouldn't get the appropriate dose. This is a lifelong medication, and it will need to be adjusted as the child grows. So make sure you're teaching the importance of labs, follow-up care, and things like that. They also need to know how to prevent hypothermia and to increase fiber to help with that constipation. Some other things that are going to happen is, like I said, monitoring that growth and development and monitoring those TSH and T4 levels throughout their life. And then, that's how the medication is going to be adjusted. You also need to teach signs and symptoms of overdose. So that would be signs and symptoms of hyperthyroidism, and then signs and symptoms of ineffective treatment or ineffective dosage. With that, you will see signs and symptoms of hypothyroidism. With hyperthyroidism in the pediatric patient, usually it's transplacental and will go away within 6 to 12 weeks. It can also be caused by Graves' disease. So with this, some clinical manifestations that you will see are a goiter, and tachycardia, nervousness, and increased appetite. Even though they're eating, they're still losing weight. They can be very moody, and they do not tolerate heat well at all. You'll see hypertension. They may be very hyperactive, have tremors, insomnia, irregular periods, and muscle weakness. So treatment for this, there's a couple of different medications, and then there's also radiation therapy and surgery. Talk about diabetes mellitus. And keep in mind, type 1 is most commonly found in children. So as far as pathophysiology, it's an autoimmune inflammatory process resulting in the destruction of those beta cells in the isolates of Langerhans. So generally, there is a genetic predisposition with this. So it's the most common metabolic disease in children. This is where no insulin is produced, therefore the cells of the body are unable to utilize that glucose, eventually spilling glucose into the urine, as you can probably remember from some of your previous courses. The body will compensate for the loss of fuel by breaking down fat and protein. That's where those ketones are formed, and this also results in metabolic acidosis. So 80% of the beta cells have to be destroyed before hyperglycemia develops. Signs and symptoms of diabetes mellitus type 1, this should be a refresher on what you have already learned. So keep in mind, some signs and symptoms are going to be that hyperglycemia. You've got the 3 polys, polyuria, polydipsia, polyphagia. You've got some weight loss. That's generally 30% with protein and fat breakdown. You've got some blurred vision, fatigue, headaches, and then ketoacidosis. So that's going to be where their glucose is above 300. Normally, their serum pH is below 7.25, and that's because of that accumulation of ketones, and the pilling in the urine will cause the pH to decrease. So that spilling goes over into the urine. And then you have elevated urine ketones. That's due to that accumulation and spilling into the urine as well. You can also have abdominal pain, nausea, and vomiting. That fruity breath is pretty characteristic, as well as those Kussmaul respirations. And those also indicate that metabolic acidosis. So when we look at metabolic ketoacidosis, this can occur if the child has an extensive amount of sugar intake and no additional insulin. The body burns fat and protein stores for energy. So when no insulin is available to metabolize that glucose, that's what happens. So then you're going to see that altered consciousness, and that is going to occur as those symptoms progress. So, kids don't understand how to manage their diet, and that's a big thing for children. Diagnosing pediatric patients with diabetes mellitus type 1, it's going to be based on those classic symptoms. And then you're going to need that definitive diagnosis. So you've got that hemoglobin A1C is greater than 6.5. You've got a fasting glucose of above 126, and then you've got a 2-hour 75-gram oral glucose tolerance test, and those results will be above 200. Also, a urine sample with high glucose levels and ketones can be used. So treatment for diabetes mellitus type 1, you've got the insulin with the sub-Q injection or pump, because you guys remember, you can't use oral hypoglycemics with this. Regular glucose testing and glucose goals are going to be higher for infants and toddlers. You also have regular urine testing, so that's every 3 hours when they're sick. They're going to be on a diabetic diet, daily exercise, and monitoring of that hypoglycemia. So, just keep in mind that orals can only be used in type 2 because there's some insulin available, and we can try to stimulate the body to produce more. But type 1, it doesn't have anything that works. So you can use a combination of fast-acting insulin and long-term insulin. So you've got that regular glucose monitoring that's going to be needed. Hypoglycemic episodes are very common in children because of metabolism and those growth changes. Diabetic diet is generally tailored to the child's food preference, personal likes, and cultural norms. So there's not really any forbidden foods with children. The goal kind of is 50 to 60% carbs, 20 to 30% fats, 10 to 20% proteins, and their food intake is going to, you know, be kind of centered around as close to those peak action times of the insulin as possible. So you also want to be promoting daily exercise to promote that optimal usage of that glucose. So they can play sports. They just need to plan out for it. And we're going to talk a little bit more about that going forward. Also, stress management is a big thing for children. Now we're going to be talking about hypoglycemia. So this is going to be where their blood sugar is less than 60. So generally with kids, it's going to be a very rapid onset. They're going to be irritable, pale, diaphoretic, hungry. They're going to have difficulty speaking. You're going to see a behavior change, such as they're nervous. You know, you may see temper tantrums, especially in children, and then more anger in older children. Poor concentration, confusion, tachycardia, headache, dizziness, vision disturbances, and shaking, as well as tremors. We're going to talk about managing those episodes of hypoglycemia as well as nursing considerations. So you want to make sure that they are ingesting simple sugar. So things like hard candy and glucose tablets if their blood glucose is less than 60, indicating that hypoglycemia. If the child is unconscious, they're going to get an injection of glycogen. So you want to try to identify the cause to prevent these. You know, are they doing sports and they're not having snacks? Because anytime they increase their exercise, they're going to need some snacks to make up for that, right? So education is very, very important. You're going to be educating on signs and symptoms of hypoglycemia, administering that glucose glucose testing, insulin administration, meal planning, and physical exercise. Again, remember, they need to have snacks before exercise. Um, Also, emotional support is very important. So when we're educating them about the glucagon, the injection is a hormone that stimulates a release of glucose from the liver. So some adverse effects with that is nausea and vomiting. So you always want to place the kid on their side after that injection. Um, you know, when you're thinking about nursing interventions, you know, with these kids, you're going to be looking at vital signs, level of consciousness, are they hydrated, those blood sugar checks, assessing their dietary intake, and ability for the family and child to manage care. You know, keep in mind that parents may feel guilty. They're going to need resources and they're going to have educational needs, so you need to help meet that. Growth and development, you want to make sure that that's happening at a proper level. Adolescents might deny any issues. Keep in mind, you know, are they able to afford supplies, follow up with appointments, and then encouraging those kids to do self-care and treat them just like they're any other child. Chart of different types of insulin. This one is more focused on rapid acting. So keep in mind that these are great if a child is a picky eater or a toddler, and they can be taken right after a meal, you know, just to make sure that they eat something, because kids are very picky. Few of those short-acting insulin. So things like regular insulin, Humalog or Novolog, and then the one that is used in the pump. So keep in mind that short-acting insulin covers insulin needs for meals eaten within 30 to 60 minutes. So if you aren't familiar with the different insulins, I want to encourage you to go over these charts and go back and do some research. See a chart of the intermediate acting insulin. So things, you know, like NPH, you know, this covers the insulin needs for about half the day or overnight. And this type of insulin is often combined with rapid or short acting insulin. Then you also see the long acting insulins on here, things like Lantus, Levemir. So with these, this is a more long-acting insulin, and it covers the needs for about a full day. And this type of insulin is often combined when needed with rapid or short-acting insulin. you can see, we've got some table about the pre-mixed insulin. So they're generally taken about twice a day before mealtime, and they're a combination of specific proportions of intermediate acting and short acting insulin. They can come in a bottle or an insulin pen. So when we talk about all of this insulin and giving injections, be thinking about interventions and how can you educate your clients about the administration of insulin. Keep in mind, these are needles, these are pokes, they're scary. You may have a 3-year-old that is needing insulin injections. And so how can you educate them? A good thing would be, if you think back about growth and development and their psychological and psychosocial levels that they are in, could you possibly use maybe a doll, like a little baby doll or something, and then have a maybe syringe and a needle or without a needle, and kind of show them how what's going to happen, how these injections are going to be given. That can help with their anxiety and to decrease those fears. Type 2 diabetes pertaining to the pediatric patient. So if you remember, it's a reduced insulin secretion and or cellular resistance to the utilization of insulin. Some risk factors are obesity, low levels of physical activity, a diet high in fat, and race. So you see this more common in Native Americans, African American, and Mexican Americans. You also may see a family history of diabetes and then genetics. So although the pancreas produces insulin, the cells are unable to utilize that glucose, right? So it's not an autoimmune disease at all. It is associated with insulin resistance, and most children are diagnosed between the ages of 8 and 19 years of age. Signs and symptoms of diabetes mellitus type 2 are very much the same as in adults. So you'll have the 3 polys, that polyphagia, polydipsia, and polyuria, hyperglycemia, fatigue, and then you will see a condition, it's listed here, about 60 to 90% of children will have this, and they have a dark velvety area in their skin folds. It's very, very prominent. You'll also notice that ketoacidosis is rarely seen with this. And then when we go to diagnose this, we're looking at the same as type 1. Do you remember what that is? If not, go back and review that. All right, so let's look at treatment for type 2 diabetes, specifically with our pediatric patients. So, we want to normalize that blood glucose level, decrease their weight, increase their exercise, and make sure that they are on an oral hypoglycemic agent like metformin. That's generally their first drug of choice. They may need injectable insulin if needed as well. And how can you teach them about how to inject insulin? Do you remember what we talked about a little bit ago with the doll and the syringes? Depending on the age, you can even do this with toddlers. 8-year-olds, that's a great example of when to do that as well. And then their diet. So, you want to focus on glucose monitoring and then weight control regimen. They can, have physical exercise, and that's a great way to help promote how they can control their weight. So you want to encourage those exercises and sports with these kiddos. So the nursing considerations for type 2 diabetes mellitus is going to be the same as type 1. You're going to be monitoring that blood glucose, promoting diet, exercise, and then education. Family-centered education is excellent with all of these diagnoses. So, make everything a family-centered event. The family can all eat healthier together. They can exercise together. They can be involved in sports. So, involving the family in every aspect of education, no matter what the disease or disorder, is important with pediatric patients. So I appreciate your time. I appreciate you learning and listening with me, and don't hesitate to reach out if you have any questions. This ends this presentation.